The guidelines of the American Academy of Neurology and the American Epilepsy Society are helpful in that they are based on evidence-based literature, so that they're the best quality studies we have, and they produce information about what we can prove about using these drugs to treat epilepsy. The weakness of them is that they're very limited in terms of these prospective controlled studies that don't frequently resemble how we take care of how we take care of patients in the clinic. And so that, obviously really you need clinical experience and expert experience to supplement that in order to make a decision about how to treat a patient. For someone like myself, who's an expert, quote, expert or epileptologist, they really don't impact much on our practice. In other words, that's the literature that we already know and that we've used to build our practice. For the less experienced or the clinician that's less invested in the treatment of epilepsy patients, it can be very useful to know what's in the literature to support the use of the various drugs in the various situations. So it's helpful, I think, in a limited way, but the more experience you get, I think they become less and less important in terms of impacting on your treatment decisions. So I've been practicing for a long time, and when I initially started to practice, we only had 5 drugs to choose from, so it wasn't too complicated, and we had to use those drugs in patients and in order to gain control of their seizures. The biggest change over the years with the advent of many new medicines is improved tolerability. We now have drugs that are much better tolerated, have fewer drug-drug interactions, and likely have much less in the way of long-term side effects. So when I'm choosing drugs now, I pretty much only use the newer drugs, and by that I mean drugs from 1995 on, where tolerability is better, safety is good, and the efficacy is at least comparable to what we had back in the good old days. It's important to understand that the use of blood levels in monitoring anti-epileptic drugs is not evidence-based. There are few, if any, studies that are really class 1 studies or whatever looking at the role that blood levels should play in managing patients. And there's a wide variation in clinical practice between epileptologists in the field. Myself, I think I'm on the side that likes to use drug levels more, find them useful. I think we all agree that drug levels are important and helpful early in the management of a patient, where we establish what we think is a therapeutic dose. We check a level, and that kind of reinforces that this is the patient on 200 milligrams, this is their level, and then as you go forward, you can make comparisons. It helps guide maybe what dose you choose for some agents, and it also helps check for compliance or adherence down the road when they show up in the ER for a breakthrough seizure. You do a level, the level is non-detectable, and it's very clear that non-adherence has been a major contributor to this seizure. There are certain drugs that I think levels are more helpful or more important, and those are drugs that have a lot of drug-drug interactions or who have a wide inter-individual variation between dose and level. For an example, lamotrigine is a drug where I find levels very helpful because there's drug interactions in terms of enzyme inducers lowering the level, estrogen lowering the level, valproate raising the level. In addition, if I give you one patient 200 milligrams, their level could be 4, another patient might be 12. And so that inter-individual variation and the drug-drug interactions or whatever make AED levels very helpful in a drug like lamotrigine. Conversely, levetiracetam, I think, is a drug that levels are limitedly useful. In that there are no drug-drug interactions. Usually there's a very close correlation between patients and dose in terms of what the level is. And also the side effects don't seem to parallel the dose or the level, so that it's a drug that can be used very readily without the use of levels and not be very limited. Many people ask how the mechanism of action should impact on drug selection. For me, not much. There are some people that rely heavily on taking one from column A, sodium channel blocker, one from column B, GABA enhancer, and maybe one from column C, a different mechanism or whatever. But we have to understand that one, the mechanisms are proposed, not usually proven or documented, and even if you've used a sodium channel drug, it's very clear that a different sodium channel drug has efficacy and may be the next best agent. That said, I do like to spread around the options in terms of, after I've used a couple sodium channel drugs, say lacosamide and lamotrigine, I'm probably not going to go there for a third sodium channel drug, and I'm going to move to something different, such as levetiracetam with the SV2A binding, or maybe a GABAergic drug or a multi-proposed mechanism like topiramate.